Hello, everyone. I'm Chi-Shin Tseng, and I'm a urologist at National Taiwan University Hospital in Taipei, Taiwan. Today, I'll be talking about salvage radiation therapy to prostate bed only among those patients with PSA recurrence after treatment with radical prostatectomy. First, I want to talk with you about some prostate cancer facts in Taiwan. We have about 5,000 newly diagnosed cases every year, and we know radical prostatectomy is the most common form of treatment employing men with prostate cancer. Nearly 3,000 cases undergo radical prostatectomy every year. Like any modality for prostate cancer, there are treatment failures. In terms of biochemical recurrence, it really depends on pretreatment factors, depending on which of the series is quoted. Usually around 1/3 of patients relapse at 5 years. So a rough estimation of 1,000 patients need salvage therapy. Regarding treatment for biochemical failure, if one looks at NCCN guidelines, it's very interesting because it still allows observation involving monitoring the course of disease in certain patients. But normally, standard treatment is salvage radiation therapy with or without ADT. There's a whole bunch of clinical trials looking into the different treatment combinations and modifications. But virtually none of the current trials focus on SRT to the prostate bed alone. What I think is interesting to start with, what's the simplest and the most effective way to treat patients? And how do we optimize the outcome by patient selection with simple indicators? So about 15 years ago, we started to follow 105 men with salvage radiation therapy. And the median follow-up duration is 38 months in this cohort. The definition of biochemical failure is appearing 2 consecutive PSA values above 0.2, since all cases underwent SRT when their PSA levels were below 1.5. The ADT could be awaited, and the only target is the prostate bed. So overall, in this cohort, about 37% of patients were free from biochemical failure at 5 years, and 66% of patients were free from metastatic disease. It is worthwhile to note that quite a number of cases had EPE or ECE, which is extraprostatic extension, and also seminal vesicle invasions and positive surgical margins, so which is quite a real-world series. Several parameters were characterized and tested in multivariable analysis. I think these are the 2 most important pieces of information that are the key factor in this study. So the first one is the pre-radiation PSA level. If it is lower than 0.45, it can predict better BCR-free survival. And the other one is PSA doubling time. If the PSA are shooting up with a very short period of time, that's very dangerous. So the PSA numbers don't double within 8 months. I believe it's a good indicator for metastasis. So here we utilize these 2 factors to stratify our cases. On the left side of the slide, we had patients stratified with pre-radiation PSA by 0.45, which demonstrates modest control in BCR. If we treat patients earlier, we had better progression-free survival. But the pre-radiation PSA show limited effect in predicting metastasis. On the right side of the slide, we stratified patients with PSA doubling time by 8 months, which demonstrates significant control in terms of ADT use and metastatic disease. There's a wide gap between the 2 survival curves. So these 2 factors are very predictive for different outcomes. So why don't we combine them into the numbers of risk factor, such as 0, 1, or 2 risk factors? Then we stratify our cases into these risk factor groups. Surprisingly, the zero risk factor group appears the most beneficial. And 74% of the patients were free from biochemical failure at 5 years, and 100% of patients were free from metastatic disease. On the contrary, we have to pay attention to those patients with high risk for SRT failure. In our series, we can identify these patients by either PSA, which is higher than 0.45, or PSA doubling time less than 8 months. But in this old historical risk group, like stratified by ASCO, which is obviously out of date because we know that the pre-radiation PSA level is very crucial to predict further BCR or metastasis, and which is around 0.4. But here, the pre-radiation PSA is over 1, which is way too high. So the definition of this high risk by ASCO is too risky. The other way around, the low risk doesn't guarantee low risk of metastatic disease, so it's not safe. Another definition appears in GTAC-16 trial, which has a relatively benign cohort with very low pre-radiation PSA, around 0.3. So the high-risk group includes PSA doubling time less than 6 months, which I agree, but with Gleason score, margin, or seminal vesicle invasion. Like these stratification fail to reflect the benefit of ADT, which means this stratification is not effective. So since the pre-radiation PSA is low, these patients are relatively safe. Here's the last one. The EAU risk group is also, the purpose is also to stratify patients into high risk or low risk. However, the kin of predictor or pre-SRT PSA level is missing here. The PSA level was proved to be highly protective in the validation study, and the cutoff value was also around 0.5. So in actual practice, we would suggest that we should treat these patients very early when their PSA is still below 0.45. If their PSA numbers don't double within 8 months, I believe they are good candidates for salvage radiation therapy to the prostate bed alone, and without any subsequent ADT. In this way, we can save patients from the pain of unnecessary treatment and also provide the best outcome for these patients. Thank you for listening.